I might stay closer to here just because there's some stuff I have to do. I hope that doesn't confuse you guys too much. But you can look over there. I won't get offended if you don't look at me. And are the lights okay? Does anyone need them down a little bit so I can nap? Or turn them down and let everyone stay awake?
Here, do you want to check? Is that better? Whoa.
Yeah, there you go. Is that okay? All right, I think that's a good balance. All right, so this is, I was asked to talk about respiratory emergencies. Some of you who regularly go to Bay Station may think this is very similar to a talk I've given before, and you would be right. But if you have any questions, just ask me. I tried to include something in here for everyone, so some of the stuff's going to be really basic. Some of the stuff's going to be kind of more advanced. But I think you guys should be able to understand it. If you have any questions at all, please just interrupt me. Any questions before we start? No? All right, awesome. So the things I'm going to talk about, some of them are directly in line with the local protocol. Some of the stuff is sort of for your general knowledge. It's kind of interesting where I worked in Alameda County, and our protocols, the very first page of the protocol says the protocols are guidelines. It doesn't substitute paramedic judgment. And we're actually given a lot of leeway in sort of mixing and matching things. But the other side of that was that you had to understand what you were doing, and you had to understand why you're doing it. So I certainly want you guys to follow the protocols, but I think you should probably kind of be a step above that and not only know what the protocol is, but know why the protocol is that way. And I feel like if you understand what's going on and you understand what you're doing, then you can kind of get yourself out of situations in which the protocol, doesn't entirely cover what's going on. And that's kind of one of the problems when you're writing or when you're following protocols, that patients don't necessarily fit in that box. So I think the more understanding you have of sort of the physiology and the pathophysiology, then you can do a better job. That being said, I'm going to talk about some things that aren't part of the local protocols. So just don't take something I said and then go do it and then blame me for it. Okay? Any questions about that? All right, and I don't have any conflicts of interest. So the objective is to understand the pathophysiology and the management of certain respiratory emergencies. And these are, it's not talking about obscure things. These are things you see all the time. So asthma exacerbations, COPD exacerbations, acute decompensated heart failure, CHF, pulmonary edema, whatever you want to call that, and then pulmonary embolism. Has anyone not seen one of these in the past week? It's common stuff. We see it all the time. So these cases are all based kind of on real patients. They're, none of them actually happen in this county, and they're all sort of mixtures of things. But hopefully, they'll be similar to things you've seen. Like I said, you have any questions, comments, just feel free to interrupt me, shout it out. So the first case, you get called to the park for a 15-year-old with shortness of breath. He has a history of asthma. He's been short of breath for 3 days. Seems to be worse today. Uses inhaler 10 times and didn't help. You checked it wasn't empty. His blood pressure is 155 over 102, heart rate's 140, respiratory rate's 30, and he's 88 on room air. So as you're walking up to him, you see that he's diaphoretic. Doesn't look like he's moving a lot of air. He has shallow breathing. He has retractions. He's using accessory muscles. You try to talk to him, and he's just speaking kind of 1 to 2 word sentences. So has anyone seen someone like this? Yeah. So big sick or little sick? Yeah. So there's something wrong with this guy. So that wakes you up. So which of the following things might you do as part of this treatment? And I'm not just talking about the local protocols. I'm just thinking about the management of severe asthma in general. And I'll go through them and we can talk about them. So one of the options is you could give him albuterol. You can argue about the dose, 2.5, 5. You could do CPAP. In the hospital, the CCT nurses, magnesium sulfate, 2-liter bolus, and lidocaine. So which one of these?
The medics could do CPAP also.
The medics can. I don't think they have mag sulfate anymore.
You're saying as far as mag. You're saying you can
no,
but I mean
yeah.
CPAP.
Yeah, I don't think they have mag though.
No.
All right. So which one of these might you use? Who votes for A?
Okay.
You're gonna vote for A. All right. How about B?
How old is he?
What's that? He's 15. How about C?
I got with A.
Yeah.
I was done with A.
How about D? No one wants to do D? How about E? All right, so yeah, one of the test-taking skills if more than one answer is right, and you're sure, then you should probably pick all of the above. Yeah, so all of these might be useful. And we'll sort of talk about these. All of these are, everyone would use albuterol. But we'll talk about why these other things, the magnesium, CPAP, normal saline. Anyone know why lidocaine might be used? So you will learn something. By the end of this talk, you will know why lidocaine might be used. All right, any questions so far? All right. So all of the above. So this guy has an acute asthma exacerbation. I wasn't trying to trick you with a pneumothorax or anything like that. And so let's talk a little bit about what causes asthma, and then we can sort of talk about why the different treatments for asthma work. So asthma, like diabetes, COPD, these are all chronic diseases. People that have asthma throughout their life. Sometimes they're going to be asymptomatic, sometimes they're going to be horribly symptomatic. And it kind of varies based on different things. Sort of the pathophysiology of the things that go wrong. The first one is increased airway resistance and obstruction. So you have the bronchial mucosa. In people with asthma, it's not nice and thin, it gets inflamed, it gets a lot of mucus. So you get constriction of the bronchial smooth muscle, which is where the albuterol and the beta agonists help you out. And then you start getting mucus plugs. So all these things make it harder for people to get air out. So because you can't get air out, you get this air trapping where you're breathing in and you can get air in, but it's hard getting it out. So your lung volumes go up, it's harder for you to breathe because you're having to overcome all this resistance. And then because your intrathoracic pressure goes up, you don't have as much blood going back to your heart, so it decreases your preload. This is why people with increased pressure can get hypotensive. You get catecholamine depletion, by your second or third day of a bad asthma attack. Your catecholamines are kind of spent. You're used to releasing all these endogenous catecholamines like epinephrine that, initially can help you out. But after 2 to 3 days, you kind of get used to it. You don't have a lot left. So people start getting really tired. They start not responding as well to it. And you get dehydrated. If you're breathing 20, 30 times a minute, you're not going to keep that up for very long. So all of these things together happen in an asthma exacerbation. And, we really think about treatment with beta-2 agonists, and so it doesn't show up. Well, that gets rid of the smooth muscle constriction. But if you think about it, it doesn't really address a lot of other those things. And some of those are primary and some of those are secondary. But I just want to sort of give the idea that there are actually a lot of things going on in a bad asthma exacerbation, and the bronchoconstriction is one of them, but it's not all of it. Does that make sense? So this is just a picture that's kind of saying the same thing, so try to use this pointer, that might show up a little bit. So, that one doesn't show up either. All right, so if you look at B, that's kind of looking at your normal airway. So you have that bronchial smooth muscle, the inside of the airway is nice and clear. And that's what it's supposed to look like normally, and then you go over to C, during the asthma exacerbation, it's showing all those things. The airway's inflamed, it's narrow, there's a bunch of mucus in there, there's a bunch of stuff in there. So I think it kind of graphically gives you the idea of why it's hard for these people to breathe. You're going from this, big open straw to this thing that's inflamed, it's hyper-responsive. And this is why they're miserable when they have a really bad asthma attack. Any questions about that? I like pictures more than words. I feel like I would rather have B than C if someone gave me the choice. So there's this concept of a intrathoracic airway obstruction, which is, essentially what asthma is. So the airway, you can think about it in two parts. So there's the intrathoracic airway, there's the airway inside your chest, and then there's the extrathoracic airway, so your trachea and the airway outside your chest. And they kind of respond in different ways. So when you're taking a deep breath, what happens to your intrathoracic pressure, the pressure inside your chest? Is it positive or negative? It's negative, right? That's how it works. Your diaphragm contracts, then the thoracic cavity gets bigger. So you're expanding. It's like if you have a piston and you're pulling down on the piston, the pressure inside your chest is negative compared to the pressure outside. You pull air in, and that's how we breathe normally. So when you take a deep breath, your intrathoracic pressure goes down. And so if you think about it, if you have kind of a flexible tube and you have negative pressure, so if the pressure is negative, what happens to that tube? Does it get bigger or smaller? Well, so you have a tube and then you have less pressure outside the tube, so it's going to want to expand. Yeah, so during inspiration, when you breathe in, your intrathoracic airway gets larger. How about outside, your exothoracic airway? You've got negative pressure in your trachea and positive pressure outside. So what happens to your extrathoracic airway during inspiration? It gets smaller. Yeah, so they kind of do opposite things, and that's why we divide it into different things. So during inspiration, your extrathoracic airway, your trachea gets smaller, your intrathoracic airway gets larger. During expiration, especially during forced expiration, when you're pushing really hard, the opposite happens. So you're pushing really hard, your diaphragm goes up, you're trying to push air out, so your intrathoracic airway gets smaller, but now you've got more pressure here, your extrathoracic airway gets bigger. So when do you see stridor, during inspiration or expiration? Who says inspiration? Okay, and who says expiration? Yeah, and so this is why. So during inspiration, your extrathoracic airway is smaller, and stridor is an upper airway noise, right? So stridor you're going to see most during inspiration because that's when that airway is narrowest. Problem with asthma, you've heard it's not that you can't get air in, it's that you can't get air out. So when do you hear wheezing most, during inspiration or expiration? Expiration. And that's why, because during expiration, your intrathoracic airway is smallest. So that's when the wheezing is loudest. So I think it's important, I'm sure you've all heard, stridor is inspiratory, wheezing is expiratory. If it's bad, you can certainly hear it during both cycles, but this is why. It's because during inspiration, your trachea is the smallest, and during expiration, the intrathoracic airway is the smallest. Does that make sense?
Absolutely.
Yeah, all right, I won't go over the pressure volume curve, but I think it's important to understand that because it kind of ties into what your interventions are and why your interventions work. I feel like it's not something we talk about a lot. We talk about what you see, but we don't talk about why you see it. I think it's more useful to understand what's going on. All right, so what happens when people has an asthma attack? So, if you go back to that picture, the one here, if you look at C, that's an airway obstruction. You have an airway, it's obstructed. It's not an airway obstruction like there's a peanut in there. It's not an airway obstruction like there's a piece of steak. But you have this obstruction in the smaller airways. So people have partially obstructed airways, they have a hard time breathing. You have this expiratory airflow limitation. You can get air in, but you can't get air out. And after a while, if you have all this air trapping, you can't get air in or out because you don't have any lung volume left because your lungs get so big. You get a short expiratory time because you can't exhale all the way because you want to breathe in again because you're so short of breath. So you get these increased lung volumes, and I'll talk about this a little bit later. Has anyone heard about auto PEEP or dynamic? Yeah. So you get this auto PEEP because basically you're putting all this air in and you can't get it out. So you have all this intrathoracic pressure. And that causes a lot of negative things, some of which we can affect. So the treatment for asthma, there are different things that cause it. So this is trying to talk about the smooth muscle. So basically muscles contract and relax. And there's certain things that affect, whether or not they contract and relax. There's something called cyclic AMP, which is an energy source, so lets you relax muscle. And what this is talking about is that there are different things that can sort of make the muscle contract or make the muscle relax. So beta-2 agonists, things like albuterol, they increase cyclic AMP, they cause muscles to relax. And so that's what causes your smooth muscle relaxes. So if someone has asthma and you give them albuterol, albuterol is a beta-2 agonist, it increases the cyclic AMP levels, the bronchial muscles relax, the bronchospasm gets better. There are other drugs like theophylline or aminophylline, which I hope you guys aren't seeing a lot, but it's still a treatment people use for asthma. It basically stops the breakdown of cyclic AMP. So because you can't get rid of it, the cyclic AMP levels go up, and you get more muscle relaxation. It does the same thing, it works by a different way. These M1, M2, M3 things, these are muscarinic receptors. So acetylcholine is that usually used in the sympathetic or parasympathetic nervous system? Yeah, so acetylcholine is used in the parasympathetic nervous system. If you give someone acetylcholine that's prone to asthma, it'll cause horrible bronchospasm. It's actually something you can use to test if people have asthma. You can give them acetylcholine or something that mimics it, and they get bronchospasm. So do you guys have Atrovent on the ambulance still? At some point, did you have Atrovent? Yes. No? Okay. Some people have a medicine called Atrovent, which is ipratropium, which is an anticholinergic medicine. And what the anticholinergic medicine does is by a different pathway, it blocks the contraction. So it's used more in older people, but you'll see people on something called a Dilonab or Combivent or things like that. So it's a combination of albuterol and ipratropium, so it's trying to target it by two different pathways. So one way it's doing it is trying to relax by the beta agonist. The other way it's doing it is it's trying to block these muscarinic receptors. So these are all sort of different ways to get to the same thing. There's some argument about, albuterol and Atrovent, which one's better for the larger airway, the smaller airways, but that's not the important point. The important point is there's a lot of different things you can do just to target this one thing, which is the smooth muscle relaxation. I assume on the CCT ambulances you guys have Atrovent, right?
No, we just carry it, like we get it from you guys.
Oh, okay, we give it to you, okay.
Yeah.
All right. Has anyone used magnesium sulfate for asthma? Okay, and you don't have it on the ambulance anymore. Did you ever have it on the ambulance?
Not for this.
Like in 1999, before they changed ACLS?
Long time ago.
All right, it used to be in there, right?
Yeah.
Before procainamide or after?
Not for, hard.
Well, it was right before procainamide, yeah.
Yeah.
So magnesium sulfate. There's some controversy controversy on it. I think the controversy is less and less now. But magnesium sulfate is also a smooth muscle relaxer. And people will use it for severe asthma. Sometimes they'll use it for tocolysis when someone's having contractions and you want the contractions to slow down. It's the uterine smooth muscle. But for really severe asthma, it's actually pretty effective. And we've been using it a lot more on younger kids now when they have really bad RSV or really bad asthma attack during the winter. And basically, you don't use it by itself, but you use it in addition to the beta-2 agonists, the anticholinergics. And just for your information, the adult dose is 2 grams over 20 minutes. Usually when we give magnesium in the hospital, we give a gram an hour. So if you give it that way, it doesn't work. So this is more for the nurses that go to this. But the pediatric dose is 40 milligrams per kilogram. And the only sort of issue with that is that it can cause hypotension, especially in kids. So if you're transporting a kid that's on an adjunct, just be really careful because that can drop their pressure. But that's an adjunct, and it actually works pretty well in really bad asthma in people that you're thinking about intubating, people that are going to have to come into the hospital. Any questions on that? So what do you do with a crashing asthma patient? That's always fun, right? Drive quickly. Did someone say that? And then what? Yeah. So the crashing asthma patient, basically you want to, if all you have is a beta-2 agonist, you want to get as much of the beta-2 agonist as you can. I don't know, do you guys have a way to attach to the BBM or I guess the CPAP? Yeah, so that's something we used to do. We didn't have CPAP, but we would sort of try to bag people with it, which was challenging. But if you have the beta-2 agonist, you want to give as much as you can. If you have anticholinergics, you want to use it. Consider magnesium if you have it. You guys have epinephrine, you have CPAP. Those are all good adjuncts for someone with bad asthma. The intubation is something that you really want to avoid with an asthma patient. They can't protect their airway, if they're too tired, they have respiratory failure, they're cyanotic, if you think they're going to code, then you can intubate them. The problem though, which I was trying to show you with those diagrams, is that putting a tube in their trachea doesn't fix any of the problems that they have. In a way, it actually makes it worse because now you have this big airway that they're breathing out of, and now they have this 7.5 or 802 that they're breathing out of. So it's one of the things that comes up a lot in emergency medicine that someone looks horrible, and someone says, "Oh my God, he looks horrible. Let's intubate him." And intubation doesn't always fix the problem that they have. And sometimes, especially in a crashing asthma patient, it makes it worse because now you're increasing their intrathoracic pressure. Now you're putting this tiny straw that they have to breathe through. You're taking away their respiratory drive. So it's not uncommon for someone with really bad asthma to get intubated and then code. And I'll talk about some of these things. And if you have to intubate them, you have to intubate them. But your goal should be to do everything possible not to intubate them. Yes?
Should we be giving aerosolized epinephrine?
I don't think that's part of your protocol. Yeah, things like racemic epinephrine. We used to just use racemic epinephrine. Right now people are aerosolizing normal epinephrine, and it probably works pretty well. That's more for sort of upper airway things. A lot of it will get absorbed in the upper airway, so things like crude epiglottitis. Some people even use it for angioedema. If you're going to give epinephrine, it should probably be, I don't know if your protocol is IM, sub-Q, or IV, but it should probably be through an injection. What's that?
Sublingual.
Sublingual? For asthma? Okay. Never done it that way, but that's one of the things to do. We used to do it sub-Q. IM gets absorbed more reliably than sub-Q. IV epinephrine you can give, it just, your rate of cardiovascular side effects can shoot up. And there are people that are going to go into VTAC if you give them, IV epinephrine after you're given all these beta-2 agonists. So whatever your protocol is, I would do it. I don't think nebulizing epinephrine is going to help a lot because most of that's going to get absorbed in the upper airway. And as we were talking about, this isn't an upper airway problem. This is a lower airway problem. Does that make sense? Lidocaine. You guys have lidocaine, right? Yeah. So this isn't in your protocol. But there's been a couple good studies that look at lidocaine. One of the problems is when you intubate someone, a lot of issues happen. Some of them, you get vagal nerve stimulation, you probably get acetylcholine release. So intracranial pressure goes up when you intubate someone with a head injury. Unless you're careful and do things about it, intracranial pressure will probably go up. And it's not uncommon for bronchospasm to get worse, just because of the effect from the laryngoscopy and intubation. There's some thought that, if you think about it and you have time and you can give lidocaine, this is IV lidocaine, it's not nebulized, it may blunt some of that response to the intubation, so it may prevent the bronchospasm from worsening. Most people that are intubating a crashing asthma patient don't want to take the time to get lidocaine and load it up. But it's something to think about if you know someone's going to have that and they're going to come in. Again, it's not part of your protocols. And then this thing I was talking about,